Welcome to the Art of Healthcare show, where we have interviews with experts to help us get better at helping the person with the problem. Today, I'm joined by Travis Christoffersson. Travis is a full-time science writer, the author of 3 books, Tripping Over the Truth, Curable, and Ketones, the Fourth Fuel. And he's the founder of a cancer charity, the Metabolic Cancer Therapy. Travis, welcome. It's so cool to have a chat with you.
Yeah, thanks for having me, Chris.
My pleasure, mate. And first up, thank you for rescheduling the other week when I was laid up with sinusitis. I don't think I would have had a good conversation with you that day, mate. Travis, usually what I ask people who are clinicians who come on the show is, why are you interested in the art side of healthcare? But I guess maybe a question for you should be, why are you interested in science and in communicating science to the population?
I've found my undergrad degree was biochemistry, and I just fell in love with it. So I fell in love with the science first. And just sort of through, convoluted life paths, I ended up not on the clinician side, but involved in a healthcare company. And, it just being sort of immersed in medicine, like you obviously are, and all the clinicians, you just can't help but observe and notice, and especially in America, these massive inefficiencies. And that's what sort of inspired Curable, was just looking at our healthcare system, primarily in the US. And you can start with a single chart. Just look at a chart of longevity versus healthcare expenditure, right? And the United States is just dead last, and not even by a small amount. So which just speaks volumes from this 30,000 foot view that we are just terribly inefficient at delivering healthcare. And then the question I asked in Curable is why? What are we doing wrong? Where are these inefficiencies lie? And of course, that's no small task, and it butts up against psychology, human biases, incentive structures, all these incredibly complex issues. And to try to whittle it down into something comprehensible in 250 pages was difficult. But that was the task, and that was my motivation and the inspiration.
Yeah, and it's I'd recommend everyone pick up a copy of it. It was, as I was saying to you before we hit record, and actually in the email, I had a lot of holy shit moments as I was reading through it. And obviously I'm working here in the New Zealand system, which is different to the US system, but I think healthcare systems everywhere probably have a fair amount of inefficiencies in them. One of the things that I really found fascinating with the way that you wrote the book is that you pull ideas from across the spectrum. It's not just health ideas. You talk about the Moneyball approach in baseball. You talk about Warren Buffett and Charlie Munger's approach to investing. And you talk about Kahneman and Tversky's, is that how you pronounce his last name?
That's right. Yeah, Kahneman, Tversky. Yep.
Their idea, their research around cognitive bias as well. Why did you pull ideas from those quite sort of disparate fields to healthcare and bring them into that book?
Yeah. So when you look, you sort of march through the history of healthcare, right? Go all the way back almost 2,000 years ago to Hippocrates, the famous Greek physician. And, he's usually known for his quote, first do no harm. But he also had a quote that a physician's intuition matters more than any external measurement. And that sort of ethos that puts all the burden of being a clinician on someone's instincts is really guided healthcare until today, even. And you look through history, and it was a mystical art. The practitioners were bleeding, toughening, bloodletting, just these crazy therapies that went on for so long. And what struck me as reading the history was the first well-organized, golden placebo-controlled randomized trial wasn't done until after World War II. And you look at the other sciences, chemistry, physics, were all embraced the experimental method, coming up with a hypothesis, tight experimental techniques to come up with good conclusions. And medicine just didn't do that for so long. And that then the next question is, well, humans are not purely rational creatures. They get a lot of stuff wrong for long periods of time. And that's really the work of Kahneman and Tversky. They were the first social scientists who sort of largely believed that humans were mostly rational. And that was, the kind of the baseline for social science. And these guys came along and just, two Israeli psychologists did these fascinating series of experiments and just really illustrated how irrational we really are. And, then to move to, okay, well, how do you deal with that? And you move, that's why I looked at the Moneyball thing with the Oakland A's and baseball, because baseball is a very, it's not as complex as healthcare. It's a game. It's kind of a complex game. And forever they had talent scouts who would pick the players. And it was thought that, you can't do better than these guys. They have honed their skills. It's human instinct. They can detect things that most people can't. And so Billy Beane, the manager of the Oakland A's, is like, no, these guys are subject to bias like anybody else. They're getting a lot wrong. They switched to a completely data-driven approach to hiring, to recruiting players, and fired all their talent scouts. Everyone said they were crazy, they're going to lose. And they started winning, and they had one of the lowest budgets in baseball, about 3 times lower than the highest budget of the New York Yankees. So that's just kind of, to me, was a beautiful example of how installing systems and not necessarily relying on pure instinct from a human being is a better path forward. And I'd like to, preface that or step back and just say that human instinct can be remarkable. Doctors can pick up on things, in an almost magical way. But the idea moving forward is, how do you marry those two? How do you confine decision-making through data, but let instinct still flourish? And I'm rambling here, but I'm going to go off on one more tangent. You look at chess, right? And it was always thought this was sort of the pinnacle of human logic. It's a purely logical game. And then it was the incursion of computers came in the 80s, and IBM came up with the computer Deep Blue that finally beat, I think it was Kasparov at the time, the number 1 grandmaster in chess. So now you have this incursion of data coming into a purely logical game. Now, what they've discovered is it's called advanced chess. So they have players pick an AI program and they play alongside the person. So it's each player with an AI program and the person can now detect when the AI can possibly be getting it wrong and go off instinct. And that's called advanced chess. It is better than any computer, better than any single individual. So that's a good sort of signpost where medicine could go, is this sort of marriage between, big data and human instinct.
Yeah, it's you painted a fascinating picture of that in your book as well, and it'll be interesting in the coming decades to see what happens in that space. I want to pull it back to intuition and clinician intuition. And as you said, the research shows that we're not the most rational of creatures. But how does intuition show up negatively in a healthcare setting?
So one example I can think of that was in the book that kind of struck me was, and I don't know if this is intuition or bias. I guess both, they were one is sort of the same. But in the 80s, for example, there was 2 treatments for lung cancer. There was surgery and radiation. And surgery offered a better chance for overall survival, but came with a 10% risk of death from the surgery itself. And so if a doctor said to a patient, surgery comes with a better chance of survival, but you have a 90% chance of surviving the surgery, then patients chose surgery 84% of the time. If the doctor said to the patient, surgery has a better chance of survival, but it comes with a 10% risk of death. So they framed it differently and put the death forward instead of the survival forward. Then only 50% of the patients chose surgery. So that's just an example of what should be a purely logical decision based on numbers there, even just tweaking it slightly, framing it, then the human biases come into play and alter decision making. And that goes on all the time. And with clinicians, the other thing superimposed on that is incentive structures. Humans incentives, it's just shocking how much they respond to incentives. In the US, we have the fee-for-service payment structure, which incentivizes physicians to overtreat. And this is so clearly demonstrable. About 30% of all the healthcare administered in the US is overtreatment. And largely that's because of this, this crazy incentive structure. And to give another example, when surgery for breast cancer at the beginning of the 20th century, there was a famous American physician, surgeon, William Halsted. And he came up, this was largely based on instinct, that it wasn't based on a good clinical trial, just he felt that based on what they knew of cancer, that if you cut the surgical margins farther, you're likely to get more of the cancer and there'll be less recurrence. So using that logic, he came up with the radical mastectomy, which was became this horribly disfiguring surgery. It was they would take out collarbones, sometimes ribs, all the lymph nodes in the neck, in this misguided, instinct-driven idea that you just had to try to get further out from the primary tumor. And this went on for about 100 years. Nobody questioned it. It largely comes back to the way we think of the vernacular and what words mean and biases and instincts. A radical mastectomy was something like cancer. You need radical measures, right? So it was never questioned. And then finally in the 80s, a few physicians began suspecting this was probably largely unnecessary. You might get the same results from a simple mastectomy or even a lumpectomy. And they tried to get the clinical trial done, but the surgeons that they were trying to incorporate in the trial called them murderers. They were so indoctrinated that the radical mastectomy worked that they, almost didn't participate in the trial. They had a terrible time getting it off. But then in the end, when they did this huge multi-center trial, they showed that the radical mastectomy was no better than a simple mastectomy or lumpectomy. And again, women were disfigured horribly for 100 years based purely off instinct. So when it goes wrong, it can go badly wrong.
Yeah, definitely. And I mean, you made the point earlier that when it goes right, it can almost be magical, and often it does go right. And when it does go right, and you get this kind of strange feeling, you're like, something is not quite right here. I need to go and do this, and something pops up, and you're like, okay, yeah, I don't know what that feeling was, but it was a good one to follow. But we probably have that also sometimes. And it leads us astray. Thankfully, like in the physical therapy realm that I work in, not as the results of me getting my intuition being wrong aren't as usually as devastating as a radical mastectomy. But I guess while we're waiting for AI to assist us with advanced healthcare, what are some ways that we can put maybe some checks and balances around our intuition, just to make sure that it is steering us in the right direction?
That's a great question. Yeah, you look at the hospital systems that are doing it right. And the one I talked about in the book was Intermountain Healthcare. Just an absolutely wonderful chain of hospitals in Utah and Idaho. And the way they do it is they have sort of a guy named Brent James there. He's a genius. And what he started doing was looking at the EMR, the electronic medical records system. And what he noticed right away was just massive variations in treatments for all kinds of procedures, right? And he goes, well, they can't all be right. One physician, there's got to be a best practice. One physician's got to be doing it better than the other when you have this much variation. And, medicine is often practiced in this cloud of uncertainty. We often don't have the answers, and we're clearly relying on intuition in many cases. So he just asked the question, how can we narrow this variation down and get a best practice that's best? And one example that I show in the book is the timing of pre-surgery antibiotics, right? And some doctors were giving it 48 hours before surgery. Some were giving it 2 hours before surgery. Some were giving it up to 48 hours after surgery. So what's the best time to do it? And they just ran a trial. They had the doctors that were doing it 48 hours to continue that, and had 4 different groups of time when they administered, and then measured infection rates, post-surgical infection rates. And it turns out there was a massive reduction in infection rates when they were administered at 2 hours before. So it doesn't even have to be AI. You can just look at an EMR system, look where there's variation, and then narrow it down to a best practice. And he did that from one thing to the next, and you tally all of what he did into a single metric, and it shows if everybody adopted Intermountain system, it'd lead to a 40% reduction in healthcare costs and better outcomes for everybody. Yeah, that's huge. 40%.
40%. That is massive, and I mean we're talking huge numbers here, and I mean especially in the US, the New Zealand numbers are high as well, but they pale in comparison. And if you can save 40% on that, imagine where you could deploy
Oh my
that.
gosh.
Well, you could deploy that 40% into preventative healthcare measures.
Yeah, you could
and save even more.
Roads, bridges, yeah. In the US, so 1 out of every $5 that changed hands, it's almost 20% of GDP now is related to healthcare.
Wow.
Yeah.
That's crazy.
Yeah, you think what you could do with that. That's what's astonishing. And that money, largely is wasted money. It's fraud, it's overtreatment. So, and swinging for the fences at end of life, giving people chemotherapy when they have a month to live, things like that are just totally unnecessary.
I mean, we've been talking a lot about systemizing healthcare, which is super important and makes it so much easier for us as clinicians. But there is a lot of clinicians out there who already say, oh, I work on evidence-based practice, or I work on evidence-informed practice. Maybe not ones that listen to this podcast, but for people sitting there smugly saying, I don't need to change my the way that I practice, my intuition's right because I'm basing it on these things. What do you say to that person?
Yeah, well, there's that argument. Brent James was attacked by, I can't remember the guy's name, but basically it was a philosophical argument where if you're telling physicians how to practice medicine by constantly constraining them with data or clinical pathways that insurance companies are telling them, you're going to get worse outcomes because there's always, for every 100 patients, there's one that needs something different, right? And it's up to the instincts of that clinician to detect that and do that. And his counter argument is, show me the data. If you can show me a reduction in mortality or a better disease outcome for you practicing that intuition-based medicine, show me it, prove it to me. And that's what you have to do. It's so hard for a clinician operating to see outside the confines of their practice. They have to make that claim. You have to be able to track patients and get that data, and then you'll know for sure that you're doing things the right way. But physicians don't often get that opportunity. They have to work with the statisticians, and that's the model going forward that I think we have to adopt. Is it has to be this merger of the data, the statisticians, AI is coming fast, and then letting that instinctual flourish where it can and it's best used.
Yeah,
I don't know if that's a great answer to that question. But...
No, I think it's a good answer. And yeah. I think it actually it probably leads into another question, is the bias around the data that we have, or the bias around the research that is created at the moment. And a lot of research is driven by money, by pharmaceutical companies, by people with vested interests in certain outcomes. Or sometimes in other professions where there isn't as much money, sometimes that research is driven by the preferences of an academic supervisor. And I know this is an area of interest for you as well. How do we, well, firstly, can you elaborate a little bit more around the bias of research that is out there at the moment, and maybe kind of move into how can we look to change that?
Well, yeah, it was like, what you and I were sort of talking about before you hit the record button, the art of healthcare. And the biggest way to move the needle on preventative healthcare and people's health in general is spending more time with them, and the simple things, right? The simple things like diet, exercise, social connections actually is a huge one. When you look at the epidemiological data on what matters the most, take one step back. The data using identical twin studies, it shows that about 20% of your longevity is genetics and 80% is nurture. So your lifestyle, the events that happen to you throughout your life. So within that 80%, what are the most important variables? And the top two are social connections. So very tight social connections, family, people you can really count on. And then the second one is called social integration. So that how engaged you are with the community, the number of people you talk to throughout the day. And then further down, even higher than smoking 15 cigarettes a day, diet, obesity, right? So these simple things that like our grandma knew, go out and play in the sunshine with your friends. That gets lost. And the bias there that you were sort of, I think, talking about with that research is there's a complexity bias to the newest shiny thing, right? So CAR T therapies for cancer, genetically engineering T cells to attack cancer, it's about $250,000 a treatment. That is entirely unsustainable, but it's, you know, technologically a marvel. We're always looking for incredibly the next great thing technologically, research-wise, and forgetting these incredibly important simple things. And there's massive lists of them. 2 million people in the US get hospital-acquired infections. And it shows that healthcare staff is only 80% compliant with hand washing. And about 90,000 of these people die every year. And you would dramatically reduce that rate if they would just wash their hands. It doesn't get any more simple than that. But yeah, my focus and what gets largely forgotten, these simple things, especially the biggest pernicious problem when you look at a biochemical standpoint, especially in the US, where the highest rate of obesity is insulin resistance. Over half of adults have it. It comes from just inactivity and bad diet. And metabolically, that affects everything in your body. All the 2,000 reactions that comprise your metabolism are driven less to completion. So less dopamine, less serotonin, less antioxidant systems. And that's a very addressable problem, but we just don't, there's more focus. There's research to try to get pills for prediabetes and diabetes, but there's less focus on just lifestyle. And that's, back to the art of healthcare. How do you institute that social change and get people to be compliant to that?
Do you have any answers to that one?
You guys have to figure that one out. Yeah, I think technology is playing an interesting role there. I don't know how I feel about continuous glucose monitors. You can get conscious feedback with those, what you eat and how it affects your metabolism. But yeah, no, it's a tricky issue.
Yeah, and I think, there's the wearable technologies are advancing at an interesting rate in terms of what they can do and how they can look. And I was reading a book actually by a guy called Anthony DeMello. It was called Awareness. Tim Ferriss mentioned it on his podcast, and I was like, I'll check this one out. But one of the things that he said is knowledge is great, but to make a change, you don't just need knowledge, you need awareness. So you don't just need to know the stuff, you need to taste and feel it. So even someone who is heading down a pathway towards poorer health outcomes that we know, that is wearing this wearable technology and is getting this data, often that's not enough to facilitate a change in that person's health behavior. And I don't know if that's just my intuition speaking, but it's I think it's a really multifactorial problem that we're looking to try and address. And I think if we're thinking about it from a systemic or a health perspective, a country health perspective, it's starting to get some more data around that and put cases forward towards governments to try and siphon some of that funding towards that area. But there are challenges in that as well.
Yeah. And interestingly, it kind of circles back to that social aspect we were talking about before. When people are stressed and lonely, they automatically fall back to that sort of pattern they were in before, right?
Mm.
So maybe it takes social change too, and we need, comes back to social media and how isolated people become. The rates of loneliness have gone up. In Curable, you might have remembered towards the end, I looked at the super centenarians, the people that live to 110 or longer. And it's interesting because they always get interviewed, and the first question is, well, what have you done to live so long, right? And the answers are hilarious. They range from, I drink 1 Dr. Pepper a day. One guy's like, well, I snip whiskey and smoke 12 cigars a day. One lady's like, she's like, I'm so mad I've lived this long. I've hated my life. And there's no, any single individual has no idea what they've done to make themselves live so long. But when you look and narrow it down, what you see is most of these people have had very active lives. They've never reported being lonely. And I looked at one lady in particularly, Jean Clement at France. So she lived to be 122, the longest lifespan ever recorded. And so she started smoking in her 20s, and she will only smoke 1 cigarette after dinner. And she stopped smoking when she was 117. She drank some port wine, not a lot, not in excess. She ate some dessert. She loved dark chocolate, but she had this incredibly rich, fulfilling life, lots of activities, not much stress. When she turned 100, she rode her bike to everybody's house and thanked them for wishing her happy birthday in her village. So the take home from that for me was, you don't need to be too stressed out about the perfect lifestyle, right? The perfect lifestyle is sort of an art of being happy. And that involves social integration, friends, back to that, just living a good life. And so I don't know how you design that, but it could be, just talking about this and having people interact in groups and things like that is that's healthcare too.
It is. And I think, to effectively change health outcomes, I think it needs to be a 3-tiered approach. It needs to be happening in the clinic rooms or the clinical interactions. It needs to be happening at the systemic level of healthcare systems. And also it needs to be happening at the societal level about how we live our lives and how our cities are set up and things. And
yeah,
changing one is great, but to change, if you just change one, then that can be dragged down by the others, I think. And one idea that's just kind of popped into my head from the book is that maybe a starting point that is capping the downside. And I think this is we talk about Charlie Munger and Warren Buffett in terms of they're really good at capping the downside. And this was a holy shit moment for me in the book. Whereas maybe instead of chasing after all of these amazing techniques that I need to use to help this person get better, how can I cap the downside for this person and allow them to progress naturally?
Yeah, that was Charlie Munger's inverse rule of problem solving. I think that's what, he instead of trying to find an answer or a solution to a problem, he would, what is making the problem worse, right? And I think you're absolutely right. That's a good way to approach. And that's often the case, when you look at somebody with autoimmunity, not how do you solve that incredibly complex problem through transforming growth factor inhibitors, things like that. It's what's causing that problem. And we know all this stuff, autoimmunity especially, goes back to the gut. What are they eating that's causing inflammation? So it's what's making this problem worse and taking that away instead of trying to fix this incredibly complex system. So I think as a general rule, as a clinician, that's probably a good sort of rule kind of to have especially when you're looking at zebra problems that are not obvious on a diagnostic test, things like that.
Can you expand on zebra problems for those
people
who haven't read the book?
Well, I've had some people that have reached out to me, especially recently, that have had just awful health problems that were so hard to diagnose. And it was, when you watch what they went through, they go through one specialist who would look at the problem through his eyes, right? So they would diagnose it as that. And then the next specialist who specialized in whatever they specialized in would diagnose it through their lens. And it's a classic, every man with a hammer sees everything with a nail. So, and it was, long years and years of this before they got to a real, what the actual diagnosis was. And there's so many examples of that, like these hard things like multiple sclerosis that are present with all these different sort of vague common things. People go through for years. I think the average time for an MS diagnosis is at least 7 years. So that is a big problem in healthcare, but it's not, none of this in my mind goes back to the clinician. The majority of the doctors are just fantastic human beings, well-motivated people. It's just these complex problems that humans don't really do too well at solving.
Yeah, and I think you make a really important point there, is that we look at a problem through our own set of biases. We look at a problem from our experiences and what we've been taught and how we live our lives. And that's what we see there. Whereas actually this person that's in front of us has had a multitude of different experiences to us. They've been brought up in a different way. They have different genetics to us. So they're approaching they're coming with that problem from a whole different angle to us. And I think that's one of the great things about an interdisciplinary team of healthcare practitioners attacking a problem, is that everyone comes at it from a slightly different angle. And some of the best conversations and some of the best solutions to healthcare problems I've found have been when I've been in a room with an occupational therapist and a social worker and a doctor and a nurse, and they'll say something that is common sense that I've just not been able to fathom, because that isn't the way that I look at the problem. But also I think that when we don't always have the luxury of sitting down with a multitude of other health professionals who have all had a chance to assess this person in their own way and bring something to the table. And I guess it's probably us looking to question our bias when we're looking at the problem, and even sort of adopting the experimental method if we have the opportunity to it. Sometimes things in life are limb threatening and you just need to go and do them.
Right.
But with a lot of other healthcare, we have that opportunity to experiment and to challenge our biases a little bit and to try and look at the problem from a different perspective.
Yeah. I remember when my wife was pregnant, we went to the OBGYN and I was asking him questions and he'd just say, I don't know. I gotta look that up. And he'd go back and look it up. And I just loved it because he was so comfortable saying, I don't know, but he'd want to go back and research and find out. I think of, some of these remarkable cases where intuition like that played such a huge role. In the book or the story in Curable, again, back to these sort of simple treatments that are overlooked, undervalued. I look at them like an undervalued stock, right? It's a treatment that has potentially a lot of efficacy. It's dirt cheap and kind of falls by the wayside, primarily because there's no financial interest in it. There's less of a way to make money. And one of them was this guy in the 1950s, a surgeon in Denver. And, patients would often get dysentery after surgical antibiotics. And so he had this is well before the microbiome was appreciated. And he had the suspicion, well, maybe there's an indigenous gut bacteria that antibiotics are wiping it out. And then bad pathogenic bacteria takes over and causes this dysentery. So his idea was to restore the balance of nature. And by that was a fecal transplant, what he meant. So literally going and finding a healthy person's feces, and he found it from a maternity ward next door, and just giving an enema with it, right? Restoring the balance of nature. And he did it on 4 patients. You could get by with anything back then. You didn't have to take it by an IRB committee. So he did that, and he cured all these 4 patients of dysentery. That was published, right? So it was known in the 50s that fecal transplants worked. And you fast forward decade after decade after decade, and hospital-acquired infections are getting worse and worse and worse, to the tune of, I think about 30,000 deaths in the US are in 15,000 are directly attributable to C. diff, and another 15 are indirectly attributable to it. You have about a coin flip's chance of getting C. diff if you're in the hospital for 4 weeks. So it's this massive problem, and they've always treated it with the next greatest generation of antibiotics, which has a cure rate, the first line antibiotics, of about 75%. But it had been known forever about these fecal transplants. Vets have used them, and people started doing it on their own. They looked it up, and there was a huge sort of downloadable thing on Google, how to do it at home. And about 10,000 people were doing it at home. They wanted to do it in a doctor's office, but the medical community was, again, surrounded, whatever, the complexity bias, not wanting to mix shit in a blender and be that guy in the hospital, right? So for whatever reasons, that just went on and on until they did a clinical trial and found out that it was 94% effective, and the 6% that didn't make it, you just did it again and it worked. Whereas only the antibiotics, 75% of the time it worked. And then if it didn't work the first line, your chances of it working again were less and less, until this horrible end stage of C. diff, right? And they just keep trying with antibiotics. And they took the antibiotic arm out of this trial and gave them a fecal transplant because it was working so well. Then you go to the NIH and they're like, well, we don't have no idea how to regulate this. So they talked about how to regulate it. They were worried about these nebulous, like, future problems, like if the donor came from a heavy person, that the patient, the receiver, would gain weight, right? A person dying from C. diff doesn't give a shit. They're dying, and this is a cure. So they were going to regulate it through an IND, an investigational new drug, which would effectively, just stop it, because it's such a burden of paperwork. And there was one patient there that was in the back, Catherine Duff, who saved her life by doing an at-home fecal transplant. And she spoke and, was just angry and passionate about it, told her story. And that kind of just sort of realigned the conversation back to what this risk-reward profile and how important this was. And they decided to allow it to go on, but you didn't have to do an investigational new drug, but it wasn't approved, but you could still do it. And now it's pretty much common practice in most hospitals to do fecal transplants. There are super donors, people with perfect poop that donate, and sort of you can get it from the poop bank. So the point of that, I guess, is that these incredibly effective, simple things are out there, but for these variety of biases just get pushed aside, and you can just look down the line of these things that are so obvious and simple, but just doesn't seem to be the focus in healthcare.
And I think it's about thinking differently and looking at different ideas. And I think that's probably the most simple way that we're going to be able to change healthcare and change the healthcare system to be more effective and more efficient, is by thinking differently. And you may or may not have an answer to this, but how do we get health practitioners and the people that run healthcare to start thinking differently? How do we facilitate that?
I think one thing, Chris, that's interesting to me is global capulation. Have you heard of that?
No, I haven't.
Yeah, it's probably more of a U.S. phenomenon, because you guys, so what it is, instead of having primary practitioners do fee for service, what they'll do is the primary care clinic will just say to the insurance company, give us a lump sum of money per patient. And then if this patient goes off and gets a catastrophic claim, that's on us. It comes out of that pot of money. So now the incentive is not to overtreat fee for service. The incentive is to keep your patient population as healthy as possible. And so what you find in global capulation is these clinics will hire like healthcare people to go to the patient's home, see if they're, have medication conflicts, if they are taking medication, what's in the refrigerator, Are they lonely? Sit and chat with them. What's their activity routine? What are they eating? So it's a more just immersive form of healthcare, what healthcare really is.
Mm.
So that you just using that simple incentive approach is one way to realign, I think, the way that particularly primary care physicians think.
Yeah, yeah, that's cool. And I've seen, we obviously don't have that here, but I've seen firsthand the benefit of health coaches within medical practices as well, and the effect that they can have on populations as well. Um, Travis, just mindful of the time, mate. If people are interested in learning more about you, or in reading your work, or connecting with you, how do they go about doing that?
I've been pretty bad about that. The foundation's got a website, so
Yeah,
you kind of see the projects that we have going on. Twitter, actually, I know Twitter's got its fair share of crap, but to me, it's interesting. I just kind of discovered it recently. You can, find the smartest people in the room, follow them, and get their daily thoughts, and get, they send out research articles, things like that. So it's been kind of fun for me lately. So I'm happy to anyone direct message on Twitter and chat.
cool.
Uh,
What's your Twitter handle?
oh man, I think I'd actually have to look it up, but if I
That's
think
all
you
right.
search my name, you'll find it.
I'll put a link in there as well, and you can get all your books on Amazon or wherever else you buy books as well, can't you?
Yeah,
Yeah,
correct. Yeah.
cool. Travis, what's for the clinicians, what's one thing that we should do tomorrow in our practice based off our
Ooh,
conversation
man.
today?
That's a very hard question, Chris. I don't want to have anybody think that I, have any sort of advantage over. I've written a book and studied the healthcare system, but I'm not involved like you guys are. And I think a well-meaning, smart person like you, obviously, is going to get so good at being a clinician over time. And I would never have that expertise. But to me, uh, just go back to that simple idea that we know that um, spending time with people is just critical for health. So, typically in America, primary care, you get such an incredibly limited time. And I don't know, it's just the way the system is. But if you have your own practice, you can dictate how much time you spend. But that to me seems the most obvious thing is, and you learn about people within that time. What are their issues? Um, and again, back to to me, it's absolutely fascinating, the science of social genomics. If people report they're lonely, that we know epidemiologically that their all-cause mortality, they're heading off a cliff, right? How do you fix that? Talking to them is one step. But when you look at how that does that, it penetrates all the way to the core DNA. They start to express pro-inflammatory genes and less targeted um, immune system genes. So they're constantly in this inflamed state, heart disease accelerated, Alzheimer's risk. But yeah, to me, it just goes back to the simplicity. And the other one is insulin resistance and what a pernicious effect that has on people. And I just think that, back to that simplicity, if you can somehow get people to, the majority of people on this planet, especially in Western societies, are overfed. It's that simple. We just eat too much. And we don't walk and move enough. And that just leads to this catastrophic metabolic outcome for people. And it's so widespread. And those two things, right, would go so far for reductions in chronic disease, lifespan, happiness, all those things. Sounds incredibly simple and probably hard to do, but it's right there in front of us. Those are the obvious variables.
Yeah, simple isn't always easy, but yeah, I guess it's yeah, don't get too complex tomorrow. Just go out and keep it nice and simple. Travis, mate, thank you so much for joining me and having this conversation. It's been awesome.
Yeah, thanks, Chris. Thanks for having me.
Um, Travis, you might have seen in the sheet that I sent through, I have a private community as well, and I always like to get people at the end just to pose a question to us. So we're a group of people who are really trying to push their boundaries in this area of the art of healthcare. do you have a question to pose to us that we can go away and ponder, and that's maybe going to extend the way that we think?
Oh, okay. These are all clinicians?
Probably the majority anyway.
Okay. What do you think? Okay, if chronic disease, this is probably too long. You can whittle it down for me.
Yeah.
If disease is like a tree that goes from the trunk, and this is aging, you're aging up the trunk, and then it branches out into chronic disease, right? What is the very bottom of the trunk? What starts most chronic disease, right? Because people talk about inflammation all the time. Well, what is inflammation, right? What is that? What's happening? Insulin resistance, what is that? What's happening? And, we know those two things alone are down near the trunk of the tree. Once those are smoldering, chronic disease is just starting to branch. So I would ask them, what's the beginning of most chronic disease? What's that bottom of the trunk of the tree?
Yeah.
It's a biochemical question, but it makes them think. Like I'm always amazed, like most people have an opinion on global warming, but they cannot tell you what heat is. Tell me what heat is molecularly. What is heat? Well, I don't know.
I don't know.
So yeah, it's the vibration of atoms. It's that simple. But most people will say, I'm sure there's no global warming, or I'm sure there isn't, or there is, or whatever, but they can't tell you what heat is. So with these words we use all the time, like inflammation, insulin resistance, really what is that? And is it the bottom of the very beginning of bad healthcare, or the beginnings of disease?
Yeah,
that's not an easy question, but
no, it's not. It's not. But I think it's really valuable in terms of looking at the area of the disease process that we're trying to address.
Yeah,
Are you trimming back the branches?
Yeah,
or are you,
exactly. That's it. Exactly.
It's not a great metaphor. Or are you pouring Roundup on the roots?
Right.
We probably don't want to promote Monsanto, but
but that's it. I mean, most healthcare, you're trying to solve entropy at its zenith, right? A disease state. So, tau and neural tangles in Alzheimer's patients, or the loss of dopamine cells, and how you're trying to fix something that's already broken. Well, how do you prevent it from breaking in the first place? What is that trunk of the tree where you guys can focus efforts and really make a difference? Yeah.
Awesome. I like that one. I'm going to stop the recording there.